In today's episode, we tried something different. We took ChatGPT and asked the top questions that patients ask ChatGPT about healthcare. And so we took the top 20 and we decided to answer them.
As doctors, we have the joy of answering patient questions every day. It was truly a joy answering your top 20 questions. Stay tuned for the answers. On this episode, I am excited to announce basically we've got some questions, Dr. Seth. So
That's right.
There are 25 questions that patients have asked us to answer.
We've scoured the sources.
As if we don't already answer enough questions already. But we pulled at least 25 to 30 of the top questions that patients want to have some better answers on and clarifications for. So this is an episode that really takes a look and a dive into these top questions, and we're going to do our best to answer them today.
We'll do our best.
So to start, we're going to kind of jump around with some different categories, but just general health speaking, one of the questions, how do I know if my chest pain is truly a heart attack, anxiety, panic attack, or something else?
It's a good question. So I think that's a question that a lot of people have difficult time. And I think physicians too. The patients come to urgent cares, emergency rooms all over the country, all over the world with complaints of chest pain. Chest pain is something that should generally be taken seriously.
Yeah, we don't ignore it.
Right. We do not want to ignore chest pain. I would say there's two types of chest pain that we describe. There's typical chest pain and atypical chest pain. Typical chest pain is important to identify. Those are the ones that have retrosternal, so like right here chest pain, that get worse with activity and that get better with rest. So in other words, they have pain and they go up the stairs, it gets worse, or they stop and take a breather and that chest pain goes away. Those are called typical chest pains. Those are concerning, right? Those are the ones where like you should see a doctor right away, right? Everything else is atypical. The ones where, so there's kinds where you take a deep breath in, that's pleuritic chest pain. That can be associated with lung issues. There is ones where there's palpable chest pain where you press down and, that's a painful one. Those could be rib or muscle issues. Sometimes people who have reflux, they have chest pain. In fact, 40% of emergency room visits associated with chest pain are associated with esophageal reflux disease.
Interesting.
But, do you ignore it? No. Especially if you have risk factors, your age is always like, you got to take it seriously. So those are that's kind of how I would talk to my patients.
How do you distinguish between that and anxiety?
I think that's probably the most difficult thing.
Yeah.
I think that distinguishing atypical or typical chest pain associated with anxiety is probably the most difficult thing. I think if you have a baseline history of anxiety and you know that your anxiety is associated with chest pain, that's one thing. But I would still contact a provider. I would be seen if I were you.
They say there's doctors we have tools in our arsenal, the EKG, that can really designate whether it's cardiac or non-cardiac. So
absolutely.
I'd like to know the chest pain I have on a Monday morning when I'm getting ready to go to work, what kind that is.
I have a chest pain when I open up my bank account. So chest pain, yeah, that one is a little bit different.
Excellent.
All right, question number 2. What are the early signs of type 2 diabetes?
Excellent question. Just a statistic to throw out there, 50% of the American population right now, the adult population, is considered diabetic. If you pull the statistics from 1950, less than 1% of the adult American population was diabetic. So this is truly a health concern that I would love to dive into in a different episode. But I usually will tell patients that the top most common symptoms, presenting symptoms, patients will notice an increase in urination. They will be quite thirsty. They may sometimes feel jittery. They may have some fluctuations in their weights. They may have some fatigue. But I think the telltale sign that you and I learned in medical school is there's a significant increase in urinary frequency and thirst. I remember my endocrinology professor, trying to remember his name, would say in type 2 diabetes, undiagnosed, uncontrolled, you could put a fire hose on them in their mouth, full blast, and they still would not be satiated. So
Yeah.
yeah.
And remember, like, I think diabetes is Latin for sweet urine. And originally in the old days when they used to diagnose, and I don't want to say old days like recently, I'm talking in, I think in the ancient times when they were diagnosing diabetes, it was by tasting the urine of both sweet. Now, I'm very glad that we have glucose monitors checks. But I am pretty sure that would have been a hard stop. But like, I chose not to.
No more.
Yeah, it's
Imagine being a vet.
yeah. So so we call that polyuria, polydipsia, and polyphagia, which is excessive eating. And despite drinking so much, eating so much, they urinate a lot and they lose weight.
100%. So for any patients out there having those symptoms, a simple blood test would be able to identify if there's type 2 diabetes.
Simple blood test. Okay. All right, and let's do the next question. Next question, when should knee pain prompt a doctor visit or imaging?
It's an interesting question. We get a lot of complaints, musculoskeletal complaints. I think the most common complaint is low back pain. But, knee pain, depending on the patient, obviously I'm a pediatrician as well, so I get a lot of knee pain in those prepubescent aged kids. Osgood-Schlatter's is a common condition where kids will complain of what we typically call growing pains. That's more of a reassurance to the parents at that point. For older patients or adults, you always want to find out if there's any history of trauma, falls, certainly the geriatric age, arthritis being common. I think it's also good to look at the other symptoms associated with knee pain. Are you having any redness or swelling? Does the joint look inflamed? Can you move it? Obviously I have a low threshold to do an autoimmune workup on those patients and identify if there is perhaps an autoimmune condition or even an STD. Right?
Yeah.
So
interesting story. We had a patient once who I was working in one of the northern states, and we had a young guy, and he complained of knee pain, really bad knee pain, and then he also had elbow pain.
Sure.
And my resident was really adamant about ordering an STD test. And I was like, no. And I was like, I thought it was trauma related and we should tap the joint.
Sure.
And, but there was no synovial fluid. There was limited amount. And my resident was like, I think we should check gonorrhea, syphilis test. And lo and behold, it was positive for gonorrhea.
Interesting.
Yeah.
Can't see, can't pee, can't climb a tree. Right?
Yeah, that's right.
Yeah. So I think, again, a good thorough history, and obviously there's imaging that you can order if there is a concern, or again, the physical exam, or if you're really a defensive medical doctor, they may get an MRI.
Yeah. I think
whether they need it or not.
Yeah, I think like from my perspective is like, when should you see a doctor? If you can't bear weight on that knee, right, and it's affecting your lifestyle, it's time to see a doctor. I do think physical therapy and exercise and is the precursor. Like, you need to see that all around 100%. But if you can't bear weight, if it's affecting your lifestyle, right, it's time to be seen.
Right. That's right. Right. Next question. We get a lot of patients, especially during cough and cold and flu season. Is bronchitis contagious? Is pneumonia contagious? How long does the flu last? RSV season, what are some things that patients should know about bronchitis, pneumonia, RSV, flu?
Well, I think the podcast world have become like effective immunologists and virologists that we've seen in the public over the last few years. But, as everyone knows, there's a flu season. There's cough and cold kind of seasons. the northern states are a lot more different than the southern states. That's something I was new to. I didn't realize the cold season is like August in the state of Florida. It's because everyone's inside. It's hot here. Sure. Everyone's in air conditioning. So, it's very easy to catch a cold, to catch,
They start flu vaccines around.
I think it's around the same schedule time.
Right.
But I don't think they changed the schedule for that.
Right.
And I think that's because nationally, the flu season, the way it works, but like it's very easy to get the rhinovirus or common cold. And so these things common colds last a couple days. It really depends on your immune system. If you're a healthy young individual, shouldn't have any issues. I think the problem the general public doesn't understand is there's a huge difference between a 40-year-old gentleman who's very healthy, runs marathons, and catches the common cold, and there is a difference between a 65-year-old gentleman who has a history of smoking and catches the common cold. Huge difference. That individual who has smoking, who's older, is likely to be hospitalized. So that person needs to be a lot more careful. And the thing about this is that if you get the flu or RSV, you're more you're more susceptible to getting a post-viral pneumonia, which is infection, and that causes mortality. So, and obviously hospitalization. So I think those things are things that we should, kind of make it a focus on, especially if you're in that age group. Those illnesses can last a lot longer.
Is it contagious?
So the bacterial pneumonia is not necessarily. It depends on the viral illness, and then also like the means of spread. But yeah, I mean, influenza, as we all know, is very contagious. RSV as well.
Yeah. Jumping off what you had said, not to sound too hyperbolic, but you have to be very careful if you are elderly, especially in the hospital, and pneumonia. They call pneumonia the old man's friend for obvious reasons.
Yeah. So, and I think like another thing that's really interesting in the hospital world is like, and I actually had a difficult time understanding this, is like, well, how did you catch MRSA? Have you ever, MRSA is methicillin-resistant Staphylococcus aureus. Patients who go to the hospital frequently, who are hospitalized, they're exposed to antibiotics, and they can potentially develop resistance from this. So it's not like they catch it from one person to the other. But, of course, there's instrumentation, there's instruments, there's catheterizations, and that could potentially track it. Same thing with like there's an illness called C. diff. It's not like you're getting it from one person to another. It's just that it can spread in clot and whatnot. So I think that's it's a different perspective and like contagiousness versus being exposed to antibiotics and developing it.
Yeah. Excellent.
All right. So here's a question: how can I tell if I have a urinary tract infection?
Great question. We see this a lot in women. Common symptoms are typically burning with urination, also some increased frequency, also some increased pain with urination. We call that dysuria. It's fairly uncommon in men, although you do see it occasionally. And obviously, if there is a risk for STDs, bottom line is a simple test in the office can look at that. So whether it's a urine analysis or central urine culture, I should say. But those are the top symptoms.
So I like to talk a little bit about being my hospital experience.
Yeah.
One thing that's very common is, and this is something that a lot of people don't know, a lot of times patients will come to the ER, especially elderly patients who are confused. And they'll say, my mom has a urinary tract infection. Or they'll say, my mom's confused. I don't know what's going on. And the ER provider will often do a workup, and they'll check the patient may not have any symptoms. The patient may not have any fevers. They'll be confused, and then they'll check a urine, and it will be abnormal.
Correct.
And the problem with that is they'll say, well, your mom's got a UTI. Here's your antibiotic. Come on to the hospital, get exposed, and get admitted, get IV antibiotics, and you're treated. The issue with that is, and this is something that I think as a public we need more education on, is if you don't have any symptoms, you do not have a urinary tract infection. Now, if you're confused and you can't tell the symptoms, that's a little bit different, right?
Correct. Especially in elderly women.
It is. And so that's where the clinical acumen comes in. Does the patient have fevers? Is there, what we call pyuria, which is like purulence coming out of the bladder? Just having an abnormal urine test and confusion doesn't mean they have a urinary tract infection. Those are sorry, go ahead.
Like asymptomatic bacteria.
Yeah.
You don't necessarily treat that.
Right. And so, but what it does do is it leads to overexposure of antibiotics in the public. We have so many patients who have end-stage dementia or who live in nursing homes, and they have developed crazy resistance to all sorts of antibiotics because every 3 weeks they come into the hospital, they get exposed to antibiotics, and none of that is helping. But mind you, maybe they were confused because, they're delirious, sundowning, or maybe they're dehydrated, which can also cause an abnormal urinalysis. So that's just something that I think patients should be aware of.
Are you quick to throw antibiotics at patients who call the office and say, I think I have a UTI?
Ooh, that's a good question. Because it all depends, I guess, where the symptoms are.
Right.
Like if they have classic symptoms, I am quick to
Low threshold.
Yeah, because if they have lots of urination, burning frequency, it's uncomfortable. Yeah, I'm going to provide them a 3-day treatment of a very, low antibiotic shouldn't be as harmful.
Mm-hmm.
If there's recurrent issues, and you're like, okay, well, this is the third time you're calling. Okay, let's have you see.
Right. I think it's also important. I know in my office, I'm very quick to test, and there's some outstanding lab companies now that do PCR DNA testing. You'll get results back with cultures and sensitivities within 24 hours. So a lot of times I will maybe offer supportive care until I get those results to know for sure. Obviously, everyone's different, using their clinical discretion, but yeah, there are those tests that exist. And I'm quick to also tell those patients who may have these symptoms quite frequently and their urine is fine. Obviously, checking in with the urologist, do some urodynamic studies. I've had a lot of success even with natural supplements. D-mannose, for example, is really good at helping prevent some UTIs in some women. Cranberry juice, I think that has been debunked, and the benefits of cranberry supplements. Right. There are those patients that swear by that.
Yeah.
So, yeah. Question for you. Why am I experiencing persistent headaches, hair loss, and fatigue?
When I saw this question, I was like, you need to see a doctor. That's the answer. There is a million answers to this. We could go an entire podcast into this. There can be hormonal issues. There could be stress issues. Long story short, you need to see a doctor.
Mm-hmm. I agree.
Yep.
I agree.
All right. I'll ask this one.
Okay.
How should I handle... This is not a question that should be asked to me. How should I handle everyday stress? I think I wrote this question.
When you figure that answer, you let me know.
Yeah.
Goodness. Stress. We all certainly have it, don't we? And I think for me and what I try and offer for other patients is, take it one step at a time. There's many different definitions of stress. So I just say, do your best to identify really the source of that stress. Lean on those people that are in your corner to help you out through those moments. And really, obviously, if it's at a point that it's really affecting your quality of life, know that there is certainly help out there for you. Hey, you're not alone in that. So, but I mean, stress is definitely out there.
So I think when I chat with my patients about stress, I use 4 points: eat, sleep, drink, poop.
Mm-hmm.
if you're eating well, sleeping well, drinking well, pooping well, you're most likely going to be able to monitor and manage your stress a little bit.
Yeah.
It's when one of those four are out and it's due to stress. You're not eating well, you're not sleeping well. Your body's not going to handle this well.
Yeah.
And that was my trick in handling early fatherhood. I'm not kidding. There was a book I read.
Revisit Aos 4 points.
Right. There was a book I read. It was called The Happiest Baby on the Block. It was a fabulous book written by a pediatrician. And the pediatrician wrote, because I was like, I'm about to do it. And the book talked about all sorts of like different cultures, how they don't have colic in the baby, and it basically came out to like, is your baby eating? Is your baby pooping? Is your baby sleeping? And eating, drinking, sleeping. Yeah. And I was thinking, it's just that easy. And so then I've talked to a lot of my patients over time, and I'm like, I think that might just be a little bit of the key. And I know in personal life, if I don't sleep well, I don't eat well, or I don't, and it's just this harmony that's off, and it does affect my stress.
How do you handle stress?
Well, exactly.
Yeah.
All right, I'll ask you, is there a cure for depression, and how is it managed?
That's a great question. I think there's many factors that influence depression. Obviously, certainly neurochemical changes in the central nervous system can fuel a lot of depression and anxiety. It's an interesting topic. I think there are those medicines that we are taught in medical school that certainly can help balance those neurotransmitters, which ultimately may help with those symptoms. We wanted to hopefully cure it. I don't know if it necessarily does, but I think it's a multifaceted approach. You have to look at this with these patients. What is really fueling this? And also, to your point, are you eating well? Are you sleeping well? What are those factors that may be influencing these depressive symptoms? So it may be for a different topic, but the discussion around a cure for depression and anxiety is now really looked at with some of these other molecules. LSD, psychedelics, psilocybin, ketamine. That is beyond my pay grade.
And I think that's also for like refractory depression, patients who've struggled with the illness for a long period of time are looking for a different solution.
Sure.
But for a person who comes in for the first time and says, I think I'm depressed, without suicidal thoughts, I think that the conversation in the public right now is a good one. Because when I was a kid, it was, you just take this pill. That was the conversation.
Right.
You have depression, here's your tablet. And now it's the look under the light, what's the issues, how is your activity levels, how is your food intake, what is going on in your life that has led to you to have the symptoms of depression?
This is a good example of what we do, because how often do we hear the chief complaint is depression? I mean, I would say 80% of patients that come in, I talk to them at some level about their depression. And it's easy in a traditional setting because of their workload, to just throw medication at them and say, see you later.
Yeah.
In our world, I think you and I are less quick to perhaps throw medication, but really identify what is going on with this patient.
Yep. So, all right, let's go to the next question here.
You're on the chopping block. So how much water should I drink each day?
All right. So I'm a big water fanatic. I love it, but I also take care of congestive heart failure patients. So like, there's that balance. On one group of patients, I'm telling them to restrict their water intake.
Yeah.
And then myself and normal healthy individuals, I'm telling drink water. I think
It's those days that the cardiologist is fighting with the nephrologist.
I think there's also the nephrologist and the cardiologist both agree water is not good. So I think one of the important things I think that I'd like to always emphasize to all my patients is water is premier. Like, That is the number one treatment for for water or your fluid intake.
100%.
None of this flavored water, and I hate to say this, I hate being the bad guy in that. Flavored water is not water.
Right.
Carbonated water is not water.
Right.
Sports drink water is not water. Protein water is not. Water is water. Your body is ready and developed over, millennia and evolved to manage water.
Just drink it.
Just drink it.
What about a hydrogen water?
What is hydrogen water?
Do you know about that?
No, I don't hydrogen or oxygen.
There is a hydrogen water that's maybe just a...
Oh, that alkaline stuff? Yeah. So, I mean... No.
For another topic.
So, this is... I think I read somewhere this, like, the pH of your gastric contents is 2. Like, any sort of alkaline item that you drink is going to be...
It's going to be changed.
Yeah, it's like, as soon as it comes... Exact. Just such a silly concept.
Just like water.
Water is premier. Ask a urologist. Water is the treatment for your prevention for your kidney stones. Like, so water.
Yes.
Unless you have congestive heart failure, you have hyponatremia. I would encourage you to drink 2 to 2.5 liters of water a day.
It's a conversation I have every day in the desert. So we're all dehydrated.
And especially if you're athletes, like you run quite a bit. I love to be outside and exercise a bit. I mean, the sensible water loss you have is excessive, so you have to replace it. Yeah,
100%. What diet is the best for heart health?
So I think there's been data behind, the heart healthy diets, the DASH diets. At the end of the day, the heart health diet is meant to reduce your sodium content. Mm-hmm. There are diets that are meant to reduce your cholesterol and your risk for coronary disease. Those have been studied, like the Mediterranean diets of the world, and they base that on, the Mediterranean diets, by the way, have been evaluated for a long time because, they looked at the population along the Mediterranean Sea and they said, well, these people eat a certain type of diet and they live longer. Whatever they're doing must be doing a restaurant, right? And I think that's as simple as it was. Less processed foods, items like olive oil and no fried food, that sort of stuff. Culturally, it's great food too. But at the same time, like you have to think about their culture. Like they don't emphasize, I don't think there's a hot dog eating contest in Italy, right?
No.
Where so like there's a very different perspective of how they treat food in the Mediterranean versus how they treat food in the United States. So I think that has to be taken with some nuance. But heart healthy diets in general are for lower sodium intake so that your blood pressures are not elevated significantly and you don't retain a lot of water and reduce the risk of congestive heart failure.
Even almost a little bit of, I won't say caloric deficits, but just being mindful of the amount of food that you're consuming. Right?
I think one of my medical school teachers, and I could be wrong, he was a cardiologist. He was Ronald Reagan's cardiologist, actually, when Ronald Reagan got shot.
Really?
Yeah, he was, it was a great story. I'll tell you how.
Okay.
So he told me there's been only one study in the history of medicine that's ever shown for an intervention to prolong life. And it's never been replicated in a human. Okay, and it was done in mice, and it was a full calorie diet and a restrictive calorie diet. And the restricted calorie diet rats lived far longer than those of the full of the diet. And so, now we see in all the stuff that we know that restricted diet is definitely restricted caloric intake as opposed to excessive calorie, is going to be a better situation.
Sure. Interesting.
Yep. All right. Next question. How can I sleep better and manage insomnia?
So I always push patients to have a good sleep routine. We all have these iPhones and devices connected to us nonstop. And I think that absolutely is affecting our sleep and even contributing to insomnia. And so I tell patients, try and have a good nighttime routine. So 2 hours before bed, maybe we're dimming the lights in the house. Maybe there's some soft music. We're really limiting the amount of exposure to televisions or our iPads and really preparing for sleep. I also think it's important not to eat super late. However, living in Las Vegas, Nevada, where everybody, it seems like dinner starts at 8 p.m., right? So, all that cortisol, norepinephrine surging through your blood with that could definitely lead to some poor sleep. But having a good sleep hygiene is really, really important.
I guess also limiting caffeine intake.
100.
So I know for myself, if I have caffeine past like 2 p.m., and that also changes with age. But also, like, a 10 years ago, right, there was no, like, espresso bars like everywhere. Like, now, coffee in the United States has evolved, too. People are drinking drinks with 300 milligrams of caffeine. You don't realize how much caffeine is in the normal public now. Like, it is a crazy amount. And I think there is and I actually don't know the exact number, but like the Food and Drug Administration has said that these are relatively safe, but like a cup of coffee supposedly has 75 milligrams of caffeine, and some of these caffeine drinks have 200, 300 milligrams. And I mean, I have more than a cup of coffee. I'm not saying that, but like some people drink 2 or 3 of these drinks, and they're also marketed to younger people or kids. So I don't think this is a good trend, right?
Right. And they wonder why they can't sleep. So definitely the takeaway is limit caffeine, right?
Yeah. Limit caffeine, limit the timing of the caffeine too. Right. So.
Right. Which cancer screenings do I need this person just put at my age? So I would just say I'm a 45-year-old male.
Okay.
What do I need to be looking at in terms of cancer screening?
So I believe now it has changed for colonoscopies that colonoscopy screenings start at 45 or earlier if you have certain risk factors, family history of colon cancer. But for the general public, colon cancer screening starts at 45, and mammograms for females start at 40. So for a 45-year-old individual, male and female, females need to have colonoscopies and mammograms. Sure. Men would be colonoscopies.
So get your colonoscopy.
Yes.
Or Cologuard.
Yep.
No, isn't it?
Can you tell me a little bit about Cologuard?
Cologuard is a test that you can do at home. It is not a colonoscopy, but it is a test that involves leaving a stool sample, mailing it out, gets processed, then basically it looks at DNA fragments. And it's a very sensitive test, which means you hope it's negative.
If it's negative, it's negative.
It's negative, right? If it's positive, that doesn't necessarily mean it's a cancer, but probably would warrant a colonoscopy at that time.
Now, I'm gonna tell you a little bit about my opinion on this. We're not paid by these companies, so we don't have a strong opinion on it. Cologuard seems like a good test, but the act of pooping in a bag and mailing it drives me nuts. And I don't believe patients
they're a very good company. I mean, if you send a referral, really, they are calling that patient nonstop.
And they happen to do it every year, right? Because it doesn't
3 years.
Is it every 3 years? Oh,
correct. Yeah.
Now, the colonoscopy, on the other hand, if you have a clean colonoscopy, you could have up to between 5 and 10 years of not having to have Elza, right?
Correct. Yeah, depending on the size and the number of polyps and potentially excised during that exam. But I really highly recommend the Cologuard.
I had my colonoscopy. I'm not 45, but we had just a recent reason for evaluation. I am a humongous fan of the colonoscopy. I think of all the things that we do in medicine, that is probably the best screening test that is out there. There are obviously limitations based on the prep, but also even the prep has gotten better. So as you guys know, so this is what the colonoscopy looks and feels like. So you sign up for the colonoscopy. The day before you do the colonoscopy, you have to do the prep. Mm-hmm. And so the old prep was you had to drink a gallon of this medication called Golite.
Horrible. Now,
that is definitely the most not fun part about the colonoscopy, is that you're in the bathroom, now in defense, I went through a juice cleanse, and it was very similar to that. I paid a lot of money for that juice cleanse. I thought it was supposed to make me feel better. This way, I did a colonoscopy. I had a different type of juice cleanse. But they actually put me on a different type of bowel prep, which was a different experience.
Did you do it the night before?
It was the night.
The morning of.
Yeah, that's right. And it was with a small, and I can't remember the name of the product, but the gastroenterologist here told me it was a better process. It was nowhere near as uncomfortable as Go Lightly was going to be. So the morning came. I was like ready to go. 7 a.m. we went to the scope. I remember getting wheeled in, feeling the burn in there with the propofol. 10 minutes later, I woke up in the room. My wife was smiling, excited to see me, and then I went home. It was the most pleasant part about the colonoscopy was the actual procedure and in and out of the
Propofol was good stuff.
That was the second time I'd ever had a propofol. Wisdom teeth was first. I'm going to be honest with you. I do see why patients enjoy that. So.
Yeah. It's interesting. Colon cancer is the number one preventable cancer, but it is the least screened.
Is it really?
Correct.
I wish. There's so much information out there. People educate. I think there's a lot of stigma of a colonoscopy, and I honestly think
no one wants to do the prep, and even just to add the fact that we've talked a lot about the GLP-1s,
right?
One of their side effects is delaying GI transit, is slowing up the gut. There is a prep that involves taking pills, so many and so much water spaced out, that GI docs are noting that it is not providing a clean prep. And even some of the other...
Because of the GLP-1s.
Because of the GLP-1s. If you're going to have a colonoscopy and you're on a GLP-1, make sure you hold it maybe 2 to 3 weeks prior to that anticipated colonoscopy.
Yeah, absolutely. Absolutely. All right. Question for you, Dr. Parker. Regarding LGBTQ healthcare, what is your approach and your approach in testing?
Yeah, great topic. I know we're going to talk more about this, but I certainly feel like this is a demographic of patients that I think are underrepresented, and I think we need to do a better job of talking about this or educating doctors about the importance of LGBTQ healthcare, not only from kind of a preventative standpoint, but also a cancer screening standpoint. So I lecture at one of the GME programs in Las Vegas about certain men who have certain risk factors. You need to be thinking about anal pap smears in those patients. We are seeing a rise in HPV-related anal cancers as well as oral cancers, and we are not really screening as we need to be doing. So that's one piece. I think it's important to also talk about obviously PrEP therapy, which is pre-exposure prophylaxis. If you are certainly a risk category, there are really 3 good options, about to be a 4th option.
Can you tell me a little bit about PrEP?
Yeah.
What does that mean?
Yeah. So pre-exposure prophylaxis, these are medications that you take if you are at risk for HIV.
Okay.
And it is 99% effective at preventing transmission of that HIV virus. So we have Truvada, we have Descovy. Depending on if you have any renal issues, you may want to consider Descovy over Truvada, for example. And then you have the new injectable Apretude. So these are medicines that, when taken appropriately and as prescribed, it will decrease your risk of HIV if you happen to come into contact with someone that may have the virus. The new one, it begins with an L, and I can't remember the name, but that is going to really, really change the trajectory. I truly believe not only as an HIV treatment, but also as PrEP therapy, HIV will go away. I really believe that. This is a pretty amazing molecule. So
I like it's an incredible point of, because you and I are old enough to remember.
Absolutely.
When we were in elementary school or in high school, what we used to be taught every day about HIV, the illness, and I mean the fear, right? The fears, everything that went along with it. And today,
Right.
it's a chronic illness.
Right.
It's a chronic illness.
My mom has even said, I don't want you to be gay because I don't want you to get HIV.
Yeah.
And so even the stigma that HIV is not always associated with being gay. I mean, there are certainly, I think we're all at risk, So
Yeah.
we have certain biases that we need to do a better job of teaching and educating about.
Oh, absolutely.
I think we also need to be a little bit more open. I think a lot of this demographic of patients don't feel heard as much and feel very nervous and have an open, honest conversation with their doctor about their lifestyle. And so I've always tried my best to just not judge. I mean, it is not about me when I go into these doctor appointments. It is not about me. I am there to serve and listen, and it's not about my agenda. So I think patients like this just want to be heard a little bit more and know that someone is there to listen and not necessarily pass judgment.
I think that's something that is starting to get lost in medicine nowadays. And that is like the old doctors that I don't know, maybe this is how it was in the 1800s, but like they used to pass judgment. But like there was a time that we were told that doctors were like, your job was to serve, and like it didn't matter what your personal opinion was. And I've noticed that the public is like publicly we hear a lot once in a while, and working in the hospital, you tend to sometimes go in the doctor's lounge and hear some things. You're like,
Right.
right. What do you?
There will always be that. I think there will always be that. And I'm okay with that. I know that
You're a better man than I am.
I know that I will never be able to necessarily change your viewpoint. And, obviously as a gay physician, I'm proud of who I am. That is not my entire identity. I'm not one to wave the rainbow flag. There's much more to me than being gay. But I know I will never forget a patient who did sign up for the practice and asked if I was gay. And being honest and open with him, I said yes. And he politely said, I'm sorry, I can't have a gay doctor. That's against my faith. And I said, well, I think I share that same faith with you, but I hope you would judge me more as being a great physician and not necessarily what I do in my personal life. But I'm absolutely happy to cancel your membership. So certainly another topic. But
Yeah, that's amazing.
Yeah.
So, I'll be honest with you. I don't think I would have handled it as well as you did. I don't know. That's.
But again, it's not about me.
Yeah.
He has every right to have that opinion.
Did he end up canceling his membership? Yeah.
He did.
Have you dealt with a lot of that?
Not really. Again, I hope people would judge me as being a great physician for them.
Yeah.
And not that piece. I am much more than being gay.
Yeah, absolutely.
And that's not all my identity, but I think I am a better doctor in terms of how I interact with other patients. There is certainly a softer side of me that I think makes it easy for patients to open up with me. And I think it certainly gives credit to why I think I am very successful at concierge medicine.
Yeah.
And so, but again, it's not about my agenda. I will meet patients halfway.
Amazing.
And I have a lot of LGBTQ patients that absolutely feel comfortable with me. And I feel like we just need to do a better job of be a little bit open more to these patients.
We'll just see. All right. Let's talk a little bit about telehealth.
Okay.
That's the next questions.
Okay.
So I think you said.
So, do you offer telehealth?
So we do. I offer telehealth to my patients. That's just something that and telehealth is a little bit of an interesting thing because you need to have the right software. You need to have the right, there has to be compliance stuff. So you have to go through a lot of channels, which is good. It's for patient safety. So
Sure.
So I think those things are really interesting. It's not FaceTime. You can't just call the doc, FaceTime, hammer it all out. There has to be
process.
Yeah, there's a process, and so that's for the patient safety,
Sure.
security and stuff, which is good. So yes, we offer appointments. For the patient side, all it looks like for them is they call into this, number, and it pops up. I think it's through Zoom or something, and it pops up. We have the appointment. I'm in the same time in their chart. I put in their orders, and we do an exam. There's a lot of limitations to it, though. It's not like the same as seeing the patient. Somebody said, I got this gashing wound in there. I'm like,
Telehealth would not be a good choice.
Exactly.
Or have chest pains.
Right.
That would not be a good choice.
So if you've got sneezing, sniffles, you don't really need to come to the clinic to see something. Burning with urination, and I've seen you before. That's different.
I love telehealth. And again, there's a process. I treat it like a regular office visit. So my staff will call the patient. They will verify insurance. They will verify changes in their address, etc. And then it's timed. So it is all, we are billing based on the time I'm spending with the patient. And so I love it that I use the opportunity to review labs, review imaging, save the patient a trip in, and it makes it easy for both of us. So
Yeah.
I love it.
I'm gonna have something like a little controversial spin on this.
Okay.
Now that I'm getting comfortable with doing this podcast, and we're throwing out some comments here. So I think where telehealth becomes not appropriate is how these big companies are using it to send out a bunch of medications that should be evaluated in person. So, for example, there are, without naming any names, there are some large corporations that are advertising the crap out of these medications. And these medications are prescription-based medications, whether it is for weight loss, hair loss, prostate medication, erectile dysfunction. They see these patients for like 15 minutes one time. And if you're wondering what this telehealth thing, the interviews, it's not an exam. It's not a discussion. Right. It's like, I need your name, blah, 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 blah. And like, okay, sounds good with your medical history. You've already put in your medical history in the apps, right? Mm-hmm. So, for example, one of these, the hair loss ones, I went through it with one of my friends because I wanted to know what
they really started checking the boxes.
So they do like 120 questions right beforehand. So like the patient has signed up. Do you have this? Do you have this? And they go click, 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 click the whole way down. And then by law, they have to have like a 15-minute appointment. That is a formality at best. Okay. And then here you go. Here's your subscription to some sort of medication.
Yeah.
Right. I think that's, I understand why they're doing it because it's by law they have to do it. I also see the patient's benefit of that because, like, I don't need to see them. Yeah, it's very easy. But, like, there is a role of, like, erectile dysfunction medications have a black box warning.
Right.
Right? And, like, there's so many times we've dealt with consequences of that, and you're like, how did I just get this in the mail? Well, didn't you see somebody online? Yeah, for, like, 2 minutes.
Can I tell you one of my concerns? Is how many people
sign up for this to get ED medicines, for example, how many of them are actually told that you're not a candidate for it?
I think in the 120 questions that they're asking this person to click on,
right.
Maybe they may, not tell them that they're on isosorbide dinitrate.
Sure.
They may not have been, their cardiologist refuses to pay for it.
Sure.
Their prescribe it. Their primary care is like, I'm not prescribing it. You're on this medication. But you know what I could do?
Right.
And
right.
Patients are trying to find a means to an end.
Yeah.
Right?
We're seeing that with ED medicines, hair loss. We're seeing that with certainly the weight loss medicines. And I just hope that these laces are making good, sound judgments for the best interest of the patient without letting money being the driving force.
I would venture it's not.
Next question. This one's for you. So when should I use an urgent care or they ask retail clinic or an ER?
Okay. I would hope, So the purpose of the urgent care explosion in the mid 2000s to end 2000s became huge when the ER started getting bigger. In the state of Florida, there used to be like all these signs like ER visit waits, 10 minutes, 5 minutes. And I think that's still around. And what was happening was that people were coming to the ER. The ERs were getting full. And so a lot of patients are like, well, I don't need to come to the ER for this. I could go to the urgent care. And the urgent care is a great option for patients who need to be urgently seen and do not have access to other forms of care.
Mm-hmm.
The problem right now is that they're bypassing their primary. They're not establishing care. And urgent cares are not cheap, right? Like they haven't seen you before, right? This may be their first or second time they've seen you. They're going to do a quick examination, and then they're going to order a lot of tests, right? And you may complain of some sort of knee pain or something. You're going to get a very expensive workup, mostly because they also need to figure out what's going on, and they're going to hedge a little bit on their imaging, right? So I have not seen a lot of patients come out of the urgent care with very limited treatment. They get a lot of evaluation. Tends to be expensive. ERs, even more expensive. So the way I like to describe to patients to go to the ERs, if you are having major symptoms, if you are super sick, right? You are having chest pain, severe shortness of breath, there's an emergency, you need to go see them. You break a bone, you need to go see the ER.
Yeah.
If you're kind of under the weather, right, and you need to see your primary, but you're not able to, the urgent care is a reason then too.
Yeah, I agree. But another reason why for those patients that don't even know about concierge medicine until this podcast, we do exist out there, and I think it's getting more and more popular. So
I describe to all of my patients, my goal is so that they don't ever have to go to the urgent care, and if I can prevent most of the ER visits.
Yeah, I echo that sentiment. So yes. I tell patients when they sign up to the practice that you should not ever have to ever go to an urgent care.
Absolutely.
I'm available, or we are available to you 24/7.
All the time. So, all right. I think my question's up now.
These are the tough ones.
Oof. What's the difference between premiums, deductibles, and copays?
So, to my understanding, and this is going to be a very dumbed down version, but you may have to help me go into the details, but I believe a premium is what you pay an insurance company monthly for your insurance benefits. And then, depending on the language of your insurance contract, you may have to pay another fee to the primary care physician or a specialist just for that office visit. Then a deductible is you have to meet a certain limit before insurance will actually kick in.
Right.
Can I explain that?
Yep, that's right. So if we were to say if you had a $1,000 deductible, within 1 year, because your deductibles end at the end of the year, you go to your doctor's office or multiple doctor's visits. If the bill adds up to $1,000, then after $1,000, your insurance will cover to a point. There's always a ceiling.
Yes.
Right? It's not infinite. Otherwise,
Right.
That
we broke.
Yeah, exactly. And so they'll keep it given. So there's a limit. So that deductible has to be met. And that does not include, you're right, some of the copays that happen in the clinics and whatnot. So and then the premiums are, what you pay monthly. The problem now is that the premiums are rising.
Mm-hmm.
The deductibles are rising. So you're paying monthly more and more. And then that doesn't cover you for the doctor's visits and all of the stuff. Instead of $1,000, now it's $8,000, $10,000. It used to be not that way.
Right.
And I think you're seeing in the public that they're not satisfied with this.
People are paying more and they're getting less. I just have to say, there are so many patients that will come into the clinic and have questions about their bills. And I love telling patients, I have a relationship with you not your insurance company. I am not privy to the language of your insurance contract. So if you are asking me why you're paying a copay, I can't give you that information. That is confidential information between you and your insurance company. So every patient really should take a few days to read that contract and know exactly what you're getting and how much you're supposed to pay.
And I think as a physician, it's our responsibility to help them navigate it to a point, but like you also don't want to speak beyond your knowledge about it. Like I don't know the details of so-and-so insurance company. They need to call their company and stuff. But if they need help with, arguing regarding a payment or something, I'll do my best.
And I always say if we coded something wrong, if there was truly a drastic discrepancy in a bill, yes, let me know. We can certainly dive into the background, figure that out for you.
Okay.
A few more questions before we run out of time today. Do I really need health insurance if I'm generally healthy?
I just saw something by, there's this guy on Instagram, Ramsey, who talks about David Ramsey. Yeah, he talks about controlling costs and stuff. And I think there was a question: is like, do I need health insurance? And he's like, if you are a private business owner, one medical bill could essentially wreck your entire business. So getting health insurance is not only for your health, it's for the health of your business, right? And so I think like that's such a important belief. I don't know if in the old days, we used to go to Best Buy and I remember I bought like a TV, and then the kid who was selling it to me, he's like, here, can I show you this? And then he goes, and he holds the remote and then he drops it. And then he goes, do you have kids? And I go, at the time, I had a little baby. I'm like, yeah. And he's like, you may want to consider protection insurance on the TV. Now, I was broke, so I couldn't afford it. So that didn't work. Right. But
Forget it.
I do understand his point, which is, there's possibilities of issues that could happen. So my opinion, health insurance at baseline is a necessity.
Right.
It's water, food, eat, sleep, drink, food, insurance, right? You should at least keep yourself insured. The amount of insurance you need, well, that's a discussion between you and your financial person, right?
Yeah. Last question.
Let's do it.
What is a high deductible plan, and should I pair it with an HSA? Actually, I think I want to rephrase this question. I think there's more questions that I actually personally get is, especially in a concierge setting, is I have an HSA, FSA account, Dr. Parker. Can I use that to pay for my concierge membership?
Now, remind me what an HSA is.
Health savings account.
And so this is pre-tax money that you have
From your
put
employer.
from your employer, then you put into an account just for health, can be used just for health expenditures.
Correct.
And then that's in addition to your insurance you have.
Yes.
Okay.
Yes.
So can they use it for concierge membership?
I 100% say no, they cannot.
Okay.
These are payments for medical expenses only. I'll say it again. These are payments for medical expenses only. You cannot use that for a concierge fee because the concierge fee is not a medical expense.
Right.
You are paying for access. In a direct primary care office that does not utilize or bill insurances and everything is a fee for service, yes, in a direct primary care setting, you are likely able to use an HSA or FSA account. Again, I would throw it back to the patient to have them talk to their employer or their benefits coordinator to get more details about that.
And this was just recently approved from the recent budget.
I think with the recent budget and the bill that was passed, correct.
So who knows? There may be some changes in the coming future, but from what it is, I think it's like a smaller amount. It's available. So It doesn't necessarily work for concierge memberships, but it could work for direct private care.
Correct. Okay. Yeah. And I've had patients, and this has just been trial and error. I've had patients that I've accepted that, not knowing necessarily, their payment.
Yeah.
And their employer actually checks, and they actually want invoices and show me what to take a deeper dive into in the future. But
yep,
it's been fun.
Well, thank you again. This has been a fantastic episode of Out of Network Podcasts. Again, please like and subscribe. Share it all on your social media if you can, and we'll shout it from the rooftops. Let everyone know how awesome that doctor is and how
this guy here. Thanks for watching.
You bet.